Hi, everyone. My name is Sarah Hirsch, and today I'm going to be talking to you about multi-fetal pregnancies. So, twins, triplets, all of that. This is a little bit about what we're going to talk about today, the definition and pathophysiology of multi-fetal pregnancies, risk factors and prevalence, complications and resources, and the RD treatment plans and standards of care. And I do want to give a little disclosure beforehand. There is not a lot of research when it comes to multi-fetal pregnancies and the recommendations that are specifically for twins, triplets, and all of that in regards to nutrition. Even when I was doing research and reading through the life cycle book, there was not much there. So this is what I have. I'm going to start off with the definition and some of the risk factors. When does it occur? This is when more than one embryo implants. So this is either if more than one egg is released and fertilized, or if one fertilized egg splits into two. And those two types are the identical and fraternal, or monozygotic and dizygotic twins that we will talk about later. Some risk factors for the increase of multiple pregnancies include assisted reproductive technology, or ART, namely in vitro fertilization. So over the past 30, 40 years, this has become more prevalent today. And in vitro fertilization is just when the egg is fertilized outside of the uterus and implanted after. Another risk factor is being ages 35 and up. That age group is having kids more often these days, and the prevalence of having more than one egg released at that time leads to twins or multiples. There is also the history of non-identical twins on only the mother's side of the family. And this is just not identical. Identical twins don't really tend to run in families. Here's a little bit of by the numbers. You can see the increase of birth rates of twins. If you look down at the bottom right, this is from 1980 to 2009. And as you can see, both the rate and the number of twin births have increased exponentially in those years due to some of those risk factors I mentioned before. So on the top right, we have the amount of twin births comparing 1980 and 2016. So 1980, it was 1 in 53 births, and in 2016, it was 1 in 34 births. And triplet plus births, so this is just triplets, quadruplets, any more than that. In 1980, it was 1 in 2,701, and in 2016, it was 1 in 784. So there are a few types of multifetal pregnancies, and I'm just going to talk about the two main and a few others. So there are multiple names for each of these, but I'm going to talk about the two most common. So the first is identical twins, or monozygotic. So it is one zygote or one single fertilized egg that has split into two. So these two children are genetically identical, which means they have the same DNA. So throughout life, they will look the same unless there is a change in their appearance that is influenced by the outside environment. The second type is fraternal twins, or dizygotic, which means two separate eggs. These fraternal twins may be the same gender or different. It just depends. Identical twins can be different genders, but 9 times out of 10, they are the same gender. Fraternal twins also have the lowest risk of multiple pregnancies because each baby has its own placenta and amniotic sac. So they're making sure that they get those nutrients. And then there's also triplets or more pregnancies. These can be fraternal, identical, or literally even a mix. And also those triplets or more pregnancies come with the greatest risk. And I'm going to talk a little bit more about the complications. There is substantial risk to both the mother and the baby when it comes to multiple pregnancies. This can include low birth weight, a shorter gestational age, and a lower mean birth weight. On the left here, I have some complications for both the pregnant women and the newborns. The pregnant women includes preeclampsia, iron deficiency anemia, gestational diabetes, hyperemesis, or morning sickness, placenta previa, which is just where that placenta is really low, and kidney disease, fetal loss, preterm delivery, and cesarean delivery. And in newborns, complications can include neonatal death, congenital abnormalities, respiratory distress syndrome, intraventricular hemorrhage, cerebral palsy, and low birth weight. And on the right, you can see how these all those things I just talked about, like the birth weight, gestational age, and birth weight, low birth weight rate changed from a singleton pregnancy to triplet pregnancies. So even just in that mean birth weight area, it goes down 3.7 pounds from the singleton pregnancy to that triplet pregnancy. And gestational age is 39 to 40 weeks for singleton pregnancy. It can go down to 33 to 34 weeks for triplets. And as I said on the left, as that increase in preterm and cesarean delivery as well. And finally, the low birth weight rate is 6% for singletons and 90% for triplets. And if there are triplets or more, these numbers will also slowly decrease, and that the prevalence of these complications will increase as well. Here I have a few resources for families of multiples. Be aware that everything such as WIC, pre-to-3, all of that is still applicable for these families. These are just some resources specific for these families of multiples. So Raising Multiples and Multiples of America, these are online resources that provide education and ample research for mothers who are raising multiples. So if you have any questions, anything like that, this is the place to go. And the Office on Women's Health, this is with the USCA, and they also have a lot of resources. I think they have a database available for resources as well for raising multiples. And last, we have the nutrition needs for the mother and the baby. And keep in mind, as I mentioned before, there is not solid evidence for caloric intake and breastfeeding. This is all extrapolated data based on averages and past a very, very few amount of past studies. So this is definitely something, if you're going into the pediatrics field, this might change over the next however many years as studies come to fruition about this. So on the left, we have the average weight gain for normal, overweight, and obese. That weight status will be pre-pregnancy. So if you have a normal pre-pregnancy weight gain recommended is 37 to 54 pounds. If you're overweight pre-pregnancy, that'll be 31 to 50 pounds. And for obese individuals, it'd be 25 to 42 pounds. And with that weight gain also comes increased need for calories for yourself and the baby. In that first trimester, no matter if it's twins, triplets, quadruplets, it'll be 300 kilocalories more per baby. That'll increase to 340 kilocalories for the second trimester and 450 kilocalories more per baby in the third trimester. And then for breastfeeding, that increased caloric intake also continues after the baby is born. So for the first 6 months of breastfeeding, the mother will want to intake 500 kilocalories more per baby per day. And for the next 6 months or more, 400 kilocalories per baby per day in addition. And keep in mind that all the normal nutrient needs, such as wanting to get DHA, those omega-3s, apply not only to singleton pregnancies, but multiple pregnancies Another complication that for feeding is trying to get the babies on the same feeding schedule. So one will want um, pump, to have a bottle while you feed that other baby as well. And premature infants may not reach stages as fast. And here I just have a little bit of a review on what to eat, what not to eat while pregnant. So obviously we want to stay away from those raw fish, alcohol, caffeine, excessive amounts of caffeine. And then we want to increase those leafy greens, dairy, the fatty fish, and that. And that is all I have. So thank you all.